Ladies and gentlemen, my name is Rainer Sauerborn. I have the honor to moderate this panel. I will introduce the panelists after a little introductory word, and that is about the role of physicians. Now, when I told my kids that I am on a panel on the view of physicians, they told me, "But Dad, you're not a real doctor." And of course, they are right. I haven't seen a patient for 20 years. So let me reflect a little bit on the multiple hats and roles that physicians may have in this climate debate. And I'll start with a slide that I always pull out to convince my kids that I once was. So a physician's views, and you see the red S. So here is myself, you won't believe it, about 35 years ago, in a doctor's role. And the gentleman there who is looking in the, to the right there, that's me. So I once was a physician working in Africa in a hospital, and we have the former hospital director, Dr. Ali here. Ali, just lift your hand. And so it was an experience, but then where does this patient come from? The lady who just had a cesarean, and she came with this donkey cart. So how long did she travel? What did she pay? Who treated her before? And why did she come so late that the outcome of the operation was unfortunately not very fortunate? So immediately you are immersed in the public health hat as a doctor, even as a doctor who provides care. You see, if you look ahead of your office or ahead of your operating room, that there is a population whom you serve, and they have quite different problems from what you know. This is a slide now, it's trying to contrast hard science with people. There's a face behind each research. We are also researchers. This is not to show off a fancy slide. By the way, it's not mine, but of a doctoral student of mine sitting there. Aditi, raise your hand. So it says this lady, we see looking skeptically at this graph, what is in it for me in this graph? This lady, if you look down there, has a higher risk at high temperatures in Nuna, in the same place that we saw the operating theater on. So on the bottom you see the maximum, on the bottom you see the temperature. This is a model based on real data, and the hotter it gets, on the very day of the temperature of 40 degrees, you have a 1.4 relative risk of dying, so of non-communicable diseases, So we have research that's really relevant for this woman, and it predicts a risk for this woman. So we had the role of care provider, public health physician. Now we have the role of physician, of researchers. Is this enough? No, we also have the role of doing something about it. So many people look to us, or public health, as people to have to change things. And here is the project Eco Cooler in Bangladesh, who use Coke bottles, cut off the cone or the funnel, and then put it in a way that the air comes in through the large part of the funnel, is accelerated, and has a cooling effect. We are testing this. It would be a great idea to have non-electricity-based cooling in very hot countries. So I just throw this to you. It's also the intervention part that we are kind of doing sometimes. So it was care, patient care, public health, epidemiology. Now we have interventions. Looking at the other age extreme, you see this girl, again from the same population in Burkina Faso, having her breakfast. But on the right, you see that chart, which shows here the timeline from pre-industrial, and here is the projection to 2100. And you see the food yields of the harvest in that area. And 100% is satisfactory. So you see they are already at a subsistence margin, and then it goes down, and it's projected to go down till the end of the century with climate change. And that has been also shown on a larger scale in Africa and India. So this child has this risk. So again, physician concerned with single people, but then looking, in this case, from a climate angle. And now you have, it's not an intervention, but it's how interventions could work to counteract this effect. And you have again the whole, you have again this, it stops at 2012, it's backwards modeling. And you see that of the added, the black curve shows the added number of child deaths attributed to malnutrition. We could prevent roughly 1/3, that's the blue arrow, with climate mitigation, if we could erase climate change. That is a model, of course. So, but we see the importance, even if you work to solve the malnutrition crisis, it's not only doing nutritional interventions or food intervention, but also working on the climate. And the author of this slide sits there. It's Christine Bedesova. So all young people who my support to do this work. So this was the reflection, and this was not to give a scientific presentation, it was just to show you there are many roles that physicians have, and we discussed this in the panel before we came together. Care providers, public health physicians, teachers, scientists, and now you will see here in the panel we have advocates, we have creators of NGOs, we have developers of new intervention, and we have communicators. So I wonder how you can wear all these hats, and of course not everybody wears this, all of them, but the panel covers all of them, I must say. And so a little grid before we started, and indeed we are a microcosmos of all these functions, and you will see this in the presentations. So with this, let me introduce the panel in alphabetic order. So Ari Bernstein is the Associate Director of the Center for Health and the Global Environment and a pediatric hospitalist. I didn't know that this word exists, probably a care provider, a hospitalist, at the Sick Children's Hospital. He has attended Stanford University for college, and he's received graduate degree in medicine and public health from the University of Chicago and Harvard. And what I liked particularly well, he really walks the talks. He's an avid bicyclist and comes in, pedals in every day, all year through. So this is Ari. Next in the line on the alphabetic order would be Vanessa. Vanessa graduated from Yale. Vanessa sits here. Vanessa Kerry sits here, is also an MD. And is graduated from Yale and Harvard Medical School, and is now at the Critical Care Fellowship at Massachusetts General. So also a real doctor, unlike myself. And but in addition, and that's very interesting, he's the co-founder and the CEO of Seed Global Health, and she talks a little bit about this. In its flagship program, Seed helped establish the Global Health Service Partnership. And she's talking about this, a novel public-private partnership with the Peace Corps, the President's PEPFAR initiative, and partner countries. So that is a small introduction of Vanessa. And now comes Lise, Lise van Susteren. She received a medical degree from the University of Paris, and interned at the Hospital of St. Anne and the American Hospital of Paris, and then trained, among many other steps in her career, to be a psychiatrist. And she's a practicing psychiatrist in Washington, D.C., and she's one of the few mental health specialists who have an interest in climate change, although this is known or anticipated to be one of the major consequences of climate change. And on top of this, she is also a CEO, so we have two CEOs here, because she's the founder of Lucky Planet Foods. But she's not talking about this. I assume you told me about this. So With these introductory words, let me ask Vanessa, if you allow first, because since I saw your slides, I thought this is a nice introductory talk, plus the special angle that you put at it, and then we take it, Lise and Aaron. Okay.
Thank you. Hi, everyone. Thank you for letting me join you. So I know this panel is really about a physician's, sort of what we worry about necessarily. Just in my role at Seed Global Health, I would argue this is caregivers in general. 90% of healthcare around the world is provided by non-doctors. So I think thinking about nurses and all caregivers and some of the things they're going to confront is important because it's really about what the patient experience is and how the patients and populations are being affected. Now that said, while I may be a physician and as a trained in the realm of pulmonary critical care, we certainly see pulmonary disease on the rise as a result of climate change. I'm actually going to take a step back to think a little bit about costing and the costs of healthcare and delivering healthcare, because this is a really real reality as a physician, because oftentimes we see patients, at least in the places of the world that I work, which are making choices about pursuing healthcare because they have costs. There's a cost to pursuing that healthcare versus sending their child to school versus some other investment. And so we need to think about this as a society in the whole. So very quick overview, and I'm going to do this in fairly short time, cover quite a bit. But what I want to just ground my discussion, and I think everything we think about, is we need to accept that health is a prerequisite to almost everything that we do in general. Specifically, health actually promotes economic stability in the world. It is fundamental, for example, to ensuring you have a productive labor force. For some households, it's a difference between being in poverty or out of poverty if you have a catastrophic health cost. And importantly, non-communicable diseases, which are on the rise with climate change. About 50% of households in insecure areas, meaning places that don't have robust insurance models, will be given a catastrophic cost from non-communicable disease at some point in their lifetime. And that it is certainly, there's now links that are very clear between health and economic growth and investment. So when we think about society as a whole and what that moves towards the possibilities for health in a country, we have to realize that health has to be, in the chicken or egg debate, there's no question to me, it is needs to happen first. And then I think just because a lot of my work is on foreign aid and thinking through political stability, and this is going to come full circle to where we go, that we have to think about the fact that health actually does promote stability. And Senators Daschle and Frist just came up with a study that looked at PEPFAR's investments over the last 15 years and found that countries that received PEPFAR funding actually had better markers of governance, better markers of peace and stability. And so this is the first real evidence that is actually really linked that access to health and health is critically important to keeping countries stable, which will come into what we're going to talk about a little bit. So I'm sure you've covered this already, but in just very quick review, climate change does impact human health. We know very well and is documented that extreme temperatures can lead to hyper and hypothermia. With increased temperatures, you get increasing pollution, allergens, and non-communicable diseases, and death and morbidity and mortality from non-communicable disease. Pollution especially relates to pulmonary and cardiovascular disease, so COPD, in some forms of ILD are even linked to this, but certainly having some, so you see very direct repercussions there. Drought, malnutrition, access to clean water sources, so that'll directly relate to infectious diseases, stunting, disaster-related events, so direct physical impact, and certainly increased incidences of infectious disease, asthma, heart disease, lung problems, higher maternal mortality. So if you study places that have undergone disaster, there's actually more deaths in the following 10 years than within the disaster itself, which is because you have a breakdown of the entire fundamental healthcare system. Mental health. I will not be spending enough time on this, but there are very directly linked costs to mental health, actually, that relate to climate change, just the stress of it alone, and the impact on the day-to-day household experience from what climate change is doing to how you have to make your decisions or you live your life or worrying about food security. In this context, there are obviously proposed cuts that are coming, at least out of our government, that we need to worry about. So the EPA is seeing the largest dollar cuts that have been put forth. But there's cuts across most departments of government, including energy, state, and treasury departments. And what that actually looks like in aggregate is that the reductions would undercut our domestic greenhouse gas efforts, clean energy development, international diplomacy efforts centered on climate change. We spent a long time negotiating Paris, and now we've basically just walked away, at least in our sort of signal to the community, and that has really real costs for what we're going to do. Now, to be fair, this debate's still out. This, to speak to our previous panel's point, this current Congress, I don't think quite knows what its relationship is with the administration. And I think the power players and actors within it are still being defined, and the appropriations are going to follow as well. But what this translates into are 30% cut to the EPA across some very big programs, importantly. Sweeping cuts to some major programs. In fact, 7 out of 42 programs on the chopping block get wiped out entirely. And some of those are very real sort of environmental cleanup projects and projects that are happening around the country here in the United States. So for the communities that live near those countries, those physicians, nurses, and health communities need to think in very real terms what it's going to mean to not have some of those cleanup projects go forward. And of course, there's sort of a $1 billion proposed cut for the Green Climate Fund, which looks at greenhouse gas emissions. So there's a seminal study that came out in 2011 in Health Affairs that looked at 6 climate change events between 2000 and 2009. And it specifically was an ozone and pollution event, heat waves, hurricanes, infectious disease outbreaks, river flooding, and wildfires were sort of the flavors of disasters looked at. But looked at 6 very specific disasters and looked at the costs of what those disasters were in terms of human health and what it actually costs to try to help care for people from direct effects of those events. And the cost exceeded $14 billion. Now, 740 million of those were actually direct costs to the healthcare system, and there was something like 760,000 visits to emergency rooms, outpatient clinics, hospitalizations, and critical care units that directly related from those events, but that cost 740 million. But 13.26 billion of it was just from premature death alone, where basically each premature death cost about $8 million. That's a really significant cost in terms of what the very real realities of those 6 events were. And when we think about real costs, we have to ask ourselves, what are costs, right? What are the costs that we're going to measure as we go forth and we think about what this is going to be on the system? So this is a bubble map that's trying to look at mortality related to climate change, but we know the costs of climate change are much more than mortality. There's both direct and indirect costs, and how do we capture those costs is the question that we have to ask. So you have a direct cost of healthcare, as we mentioned, but of that example of those 6 major disasters that happened, a far larger percentage was in sort of an indirect or potential cost, which is the loss of potential earning and the contribution of an early death. Loss of productivity of people in our communities who are being affected, loss of quality of life, and this drills down a little bit more to what you might experience as a caregiver. But health adaptation costs too. We never think about this. How are we going, what are the costs of actually adjusting to this new system or this new reality? So it's not just sort of the direct cost of coming to see the system, but you may suddenly need to pay more in terms of getting an allergen-free rug because the allergy that is outside of your house is so severe you need to minimize your internal environment as much. How do we move communities that live in very vulnerable places that are exposed to dander and cockroaches and problems like that but are now going to get hit by air pollution? How do you mitigate? And there's costs affiliated with that don't actually have to do with the real costs of healthcare. Specifically looking at mortality, there's 250 mortalities that are expected between 2030 and 250,000 between 2030 and 2050 related to malnutrition, malaria, diarrhea, and heat stress. And very specifically, that's going to cost us $2 to $4 billion a year. So what I am really, and that doesn't even include the costs of what's going to happen to agriculture, water, sanitation, and what those systems are going to have to pay for, which also relate to human health. And so what I'm really starting to ask in this sort of subtext is not how much is it, what the question shouldn't be how much does it cost us to mitigate this and to be prophylactic and to prevent it. Because in the sense that, or I guess what I'm saying is the cost shouldn't be what are we going to pay for if we have these problems. The cost should be how can we afford not to make these investments now, if that makes sense. The cost of stopping this sort of post-problem epidemic is far less than having to pay for the repercussions of this. And that's what we need to start asking ourselves. Data is scary, it turns out. Our US government has actually created some data that if they paid their own attention to, they would realize. I'm grateful the data at least exists in this day and age, but This is just the public health costing from the US government on the indoor environment, climate change impact on indoor environment. That's the cost. Indoor environment only, let alone what's going to happen externally. And this relates very real to premature deaths if you look at that right-hand column from cancer, heart disease, and SIDS. The final point I just want to make is that the most vulnerable are at risk. And this is really important. That if you look, the death rate is higher among people who make less than $36,000 compared to people who make more than $49,000. And that of the 60,000 deaths globally that we would expect, that we looked at between 2006 and 2010, the vast majority are in developing countries. And of the top 50 countries that are at most at risk from climate change, 15 of the top 50 are in Africa, where there is a quarter of the world's global burden of disease already. 11 of the top 50 are in Southeast Asia, which has 30% of the world's global burden of disease already. So the most vulnerable countries are already the ones the hardest hit. And that is a setup for a disaster. So a fellow that I work with, Dr. Vin Gupta, has looked at this, and he really looked at the political costs of this and the fact that the World Economic Forum actually said the greatest threat to global stability is going to be climate change. And if you look at an example like Syria, there's direct spillover effects to our security that come from climate change. And so if you look at Syria, though there are many multifactorial causes that have led to the conflict in Syria, the major drought that is directly linked to climate change led to huge amounts of social unrest and movements of populations. And that has very much contributed to the degree of instability that's happening in that current conflict. So Vin has coined this the climate health security nexus. And this is, we just published this in the journal in Lancet Global Health. Really looking at this exact intersection, which is that you have weak health systems. This makes these countries already predisposed to be vulnerable. You top that off with some poverty, general state fragility, and poor health. This is happening in the countries that are going to be most affected by climate change. And you can imagine the disaster that will happen out of that. And when you get into the health effects of disaster, and I mean out of crisis and out of conflict, those are obviously very severe that have years-long lasting repercussions as health systems get disrupted and broken. So with that, I'm going to end only to say this all falls within many, many other fundamental challenges that we are countering. But all of this on a very real level for me as a physician impacts every patient I see because this is the context that they're operating in. So with that, thank you.
Thank you very much. You did it. Thank you very much for really tour d'horizon. That means horizon scanning and bringing in, linking the patient view with the view on the global view, the costs, the direct costs, the indirect costs, the equity implication. That was really a wonderful introduction into our planners. Thank you very much. Now, Lise, would you follow, please, with your view as a psychiatrist and mental health specialist?
Push the arrow down. Across, okay. All right, well, thank you very much for having me. I'm delighted to be here. I'm going to start by telling you a story. When I was a medical student in France, a woman who had been treated for breast cancer checked into the hospital with back pain. Gathered outside her room, the medical team discussed her pain due to spinal metastases from her breast cancer. Sailing into the room, filled with his own authority, the attending, whom I never liked, paged through the papers and tests that filled her chart. She inquired about the results. In a breezy tone, he began talking about the pain from her sciatica. "Oh, that's a relief," she said, easing back on her pillows. "I was afraid, you know, that it was related to the other story, my history." "Ça," he said with a tone of surprise. "Oh, no, no," he lied. "C'est une histoire finie, ça. That story is over." No one on the team subsequently apprised her of the actual problem. You will see later why I tell this story. Mental health impacts of climate change. Everything related to climate change, either directly or indirectly, all the losses, injuries, illnesses, displacements, carry with them an attendant emotional toll that must be included as we tally up the psychological impacts of climate change. I'll start with a few of the mental impacts for which we have precise data, and then move on to more fluid concerns. So, did that come? Oh, yes, okay. For each standard deviation of increased temperature and rainfall, we can expect a 4% increase in conflict between individuals and a 14% increase in conflict among groups. These findings are valid for all ethnicities and all regions of the world. So, more assaults, murders, and suicides, and increase in unrest all over the world should come as no surprise. Air pollution, forming more readily at higher temperatures, particulate matter crossing into the brain via the olfactory nerve, causes neuroinflammation linked to multiple mental and neurologic problems, including cognitive decline in all age groups, including Alzheimer's and other neurodegenerative disorders such as Parkinson's disease and amyotrophic lateral sclerosis. It's also linked to autism, of course, and to psychiatric disorders. The American Psychological Association reports that children exposed in utero to air pollutants were more likely to have symptoms of anxiety or depression. Emergency room visits for panic attacks and threats to commit suicide are higher on days with poor air quality. Researchers here at the Center for Health and Global Environment show that exposing workers to increasing levels of CO2 has significant impact on their cognitive functioning. The testing at indoor concentrations to which Americans are frequently exposed shows the most serious decline in our ability to think strategically, oh, I didn't give you that, to use information, and to respond to a crisis. As CO2 concentrations rise in the atmosphere, an attendant decline in our cognitive functioning should be expected. But not everything that counts can be counted. Indeed, it is the inchoate, insidious, complex, and unconscious psychological states driven by climate trauma, not lending themselves to studies in precise numbers, that are the most profoundly damaging and drive systemic emotional conditions society will find difficult to treat and surmount. Note that we balance the need for data with the need to connect emotionally, because emotional connection is at the heart of what moves people to action. And action now turns on our success in stirring empathy. When the place you call home is burned down, blown away, dried up, flooded, when you lose your possessions, maybe your pets, your livelihood, your community, see injuries, illness, and death, the mix of fear, anger, and sorrow, and trauma can easily drive a person to the breaking point. Indeed, mental health professionals are seeing a full range of psychiatric disorders: post-traumatic stress disorder, major depression, generalized anxiety, a rise in the abuse of drugs and alcohol, domestic violence, of course most often against women, a rise in child abuse. Some of us are lucky enough to be at a distance from the world's climate disasters, but we're not potted plants sitting here. In empathic identification with the victims, it's painful seeing people drowned, burned, flooded, starved, right? Special populations that are at risk: children, the elderly, the sick, the disabled, the mentally ill, the poor, those living in the bullseye of disaster-prone areas along coastlines and rivers, tornado alleys, inner cities with the heat island effect, first responders, and climate Cassandras who suffer from pre-traumatic stress disorder in the grip of images of future disasters they can't put out of their minds. In the first published Climate Change Delusion, a 17-year-old Australian boy had to be hospitalized for refusing to drink water, believing it would cause millions in his drought-ridden country to die of thirst. The Melbourne Children's Hospital doctor who treated him told me he has a clinic full of children with climate anxieties. And though the result of multiple forces, climate change is both a threat multiplier and a root cause of the mental health crises, from the explosion of refugees today searching for safety, destabilization of regions with groups dangerous to world security rising in these feral conditions. In Europe, a sharp turn to the far right politically. The once open question about America was answered in November. In times of peril and scarcity, people regress. They turn to what they perceive as strong leaders to protect them, and are willing to give up their freedom and values in exchange for perceived security. Heaven help us from the bullies and tyrants this can, and on some occasions does, unleash. The experience of citizens stranded at the Superdome in New Orleans in the days after Katrina are an example of how quickly our systems can be overwhelmed and our faith in them turned upside down. Faith in a functional government is the sine qua non of stable society. And when disasters are no longer experienced solely as acts of God or nature, but derived from the behavior of humans, it will be much tougher on us, because what happens from intentional negligence is harder to put behind us than what happens accidentally. Whether we know it or not, whether we accept it or not, there isn't the slightest shred of a doubt in my mind that we are already full of anxiety about climate change, and we will be in a growing state of fear. Much of the violence in the world is an expression of fear about vulnerability, threatened status. It's a reason why climate skeptics often feel diminished by the forces of climate change, responding, in fact, angrily, because their impotence in the face of physics becomes obvious. Transgenerational epigenetic inheritance is carried by an on-off switch. The activation of a human gene for stress in the face of trauma can be passed on to succeeding generations, compounding the toll. A new term has been coined, solastalgia, to describe the pain of seeing lands that once gave the treasured sense of home, now lost or irreparably damaged. Should I have a baby? Is a question increasingly being asked by young people worried about the carbon costs of bringing another person into the world. As we register the warning that by mid-century, 30 to 50% of species may be on the path to extinction, and considering the life-sustaining biodiversity, the overwhelming beauty and complexity of nature, inspiring us with awe and wonder, what, as our friend Eric Shivian and Ari Bernstein would ask, is the cost not only to human health, but the cost to our souls. When we put people in harm's way, there's a name for it. It's called aggression. To our children, though they are not yet calling it this, it's clear every day that destructive, intentional inaction on climate, and this is my professional opinion, will be experienced as child abuse, with all the attendant mental health impacts we would expect. To achieve lasting change in behavior, a two-step message is critical. Number one, describe the problem in no uncertain terms and quickly follow up by saying, here is what we can do about it. The mistake is simply to state the problem with no encouragement about what can be done. The wish to resist knowing the gravity of climate change brings me to the point of my earlier story. We are in a tight spot, with baked-in consequences and CO2 that must now be drawn down. The public needs to know the truth, and with the emotional tone that reflects the message. Downplaying this crisis to keep people from being too upset, as is sometimes suggested to me, is infantilizing and prevents us from making informed decisions about what we must do. In recent interviews, children have declared they feel angry and hurt at what they see as emotional avoidance, commenting on the rising sense of abandonment, not only about the future, but the emotional abandonment they feel now when confronted by those who appear emotionally disconnected. As we contemplate the need for urgent action and the resistance to it, often left on the table is the following. Because we know that we manage what we measure, number one, the personal inventory, and creating social norms. First of all, calculating our own carbon footprint. Ironically, a deeply empowering action because it can put an end to vague feelings of guilt or denial, replacing them with a plan of action, and new things come to light. The extraordinary opportunities we have to reduce our emissions from, for example, what we eat. A plant-based diet emits a fraction of the carbon emission of other diets. How we travel. The carbon costs of airline travel are tremendous. If there's a train, take it. Our personal choices are the model for the behaviors we are calling for, powerfully influencing others, even unconsciously, and determining our culture's social norms that collectively drive markets. One last encouraging bit of news from the judicial system. in a landmark U.S. federal lawsuit in which 19 kids and Jim Hansen are suing the government and polluters for ruining the climate, the judge wrote, "I have no doubt it is my reasoned opinion that the right to a climate system capable of sustaining human life is fundamental to a free and ordered society." I look forward to hearing your thoughts. Thank you.
Thank you, Lise, for this very emotional but also very fact-based plea, which was in contradiction to what we heard before. We heard don't overstate the issue, don't make people anxious or afraid. So I'm looking really forward to a discussion which we will have at the end of the three presentations. Ari, and the floor is yours now.
So for anyone who's been in this position before, which is to say after a full day of presentations from people who know pretty much more about anything that one could possibly say and has already been said, it's a bit awkward for me to get up here and pretend I'm going to tell you something new. So you'll just have to forgive me. But I did want to start with a question, which is, for those in the room right now, would you at this moment look forward to going to see your doctor? Nobody. There's no one who likes it. That's really bad. We got some work to do. Okay. So just before I got up, I confess I looked at my phone, and it turns out that the forecast for tomorrow is totally wrong. It turns out it's going to be 120 degrees, and there's a hurricane coming, which is, probably going to inundate most of Boston and Cambridge. I don't know where you live, but you can rest assured there's going to be a lot of water and a lot of heat. Now, how many people would look forward to the opportunity to see your doctor? Oh boy, we've really got a hole. Okay, but here's the point. It turns out that many people don't want to see their doctor, and I would freely admit with good reason, I don't really want to see a doctor either. But when disaster strikes, all of a sudden people expect, particularly in the developed world, that there's going to be someone there who can patch up their limb or give them an antibiotic or do something to stem the tide. And, it'd be interesting, I don't know if Jerry Taylor and Annalise are still here, but, how do we convince people that we need to do something? I think there's a pretty compelling argument, which is why the symposium, I think, exists in some ways, to make the case to people that, your expectations about healthcare, be it in the United States or elsewhere, might not fit so well into the reality of climate change. I would fully agree that climate change is a tribal issue, right? It's not a scientific issue. It's not about what we understand about climate science. It's not even about taking that science and looking at health outcomes. It's become if you are concerned about climate change, you must be a latte-sipping, Prius-driving, biking to and from work like a crazy moron in Boston all year round, Massachusetts liberal, and not anything other than that. So finding the pathways from health into people's, as Elke Weber calls it, worry pool is crucial. And there's no question that other avenues are critical, be they spiritual, be they security, economic, those are all crucial. But regardless of where you are in society, you actually, hopefully, if you're not a psychopath, do care about your own health. And so health is a transformative piece here. And one of the things that I'm personally interested in is trying to find ways to shine a light upon how people's expectations about their health in concrete terms can be put forth as consequences of climate change. Now, whether that becomes a risk management question, as in, would you accept the risk that if there's a hurricane in Boston, all of the Boston hospitals are not going to be able to care for you, which, oh, by the way, is probably going to be true by 2100. Or if it's simply that, okay, we get it, let's try and do something about it. I really have 2 points here. The first is that it's important to recognize health as a transformative communication point. And the corollary of that is there's nobody better to communicate that than people like me. So, as you heard, the messenger is more important than the message. So if I go to Nebraska and start talking about, as a pediatrician, why climate change matters to health, it's a bit like the teacher in Charlie Brown's classroom, which, as you all know, sounds like wah, 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 wah. So even though I can articulate this and it makes sense, it really doesn't work. And that's one of the pitfalls. But that gets me to the next point, which is, you know, we've got a highly biased sample here today. I think of the panelists, it might be the majority, now certainly a lot, have medical degrees. But if you go into the mainstream of American doctors, nurses, pharmacists, social workers actually are pretty enlightened on this, nutritionists, et cetera, it ain't there, folks. And we really need to think about why that is. There have been tremendous actions in the past to try and engage the healthcare community, and they haven't landed. So in addition to asking the question of how do we effectively communicate climate change, which I would argue that's not a big secret, we heard a lot of the guidance there too, how do we get those voices? I think someone asked the question of the prior panel, how do we get these leaders to engage? In the physician community, I will speak for our own, and I can be hard on our own kind. We have not done a good job of this. I can tell you with confidence, having been engaged in this for a while now, that there are plenty of people on the, there are plenty of doctors on the coast who are certainly concerned about it, but becomes a private-public distinction, which is, as a citizen, climate change is a big problem. What does that have to do with being a doctor or my medical practice? I don't know. In fact, the first time I went to speak to a congressional office about, this was actually in the first Bush administration, about New Source Review. You may recall that there was a move to make mercury a non-criteria pollutant, which is to say, calling mercury a non-toxic element, which is sort of like calling a banana a rock. This was literally, and I had to talk next to a guy who was making the case that mercury was not a neurotoxic substance. This is a guy with a PhD. And you just have to sit there and relax. Anyway, they were shocked that someone with a medical degree, and I'm not making this up, would go from Boston to Washington, D.C. to talk about anything other than Medicare. All doctors in political activism, the median interest is about, are we going to get paid or not? So, when we think about how we get doctors to engage, I think a first point of departure is, how does climate change matter to their bottom line? And I know that sounds incredibly, I mean, to me it's almost feeling depressing to say it, but the truth is, frankly, that's where doctors in this country are. Now, to get beyond that, the good news about doctors is that I would argue we've self-menialized. We have turned ourselves into these agents of monetary transaction. But no one puts on their medical school application, and I've read them, folks, from some very good medical students. No one says, I want to turn myself into a monetary transaction agent. It is grand ideals. So we have a latent army of idealistic, smart, motivated, passionate people out there who are waiting for this to come along. So I'll stop there and say there's a huge issue around what we expect from healthcare under climate change and the reality that that may not be possible if we don't do what's necessary, and that the best people to communicate health as a transformative issue are healthcare providers, and we need to apply the same sharp lens that we would do to communications on climate change and health at a population level to that key audience of communicators. Thanks.
Thank you very much. The right kind of lively speech at the end of a day. So I think we structure the remaining 20 minutes, 25 minutes in the way that you now, the audience, ask questions, you just introduce yourself and to whom you want to direct the question, or to the entire panel. There's one question here. It's Ashish. Could you identify yourself? Sorry.
I'm a big believer in framing the issues of climate change around health, right? And major part of the reason we're having this event. Let me make one quick comment and then a question or a pushback, Ari, if you don't mind. So I think there are lots of issues that physicians, the medical community has championed that is not directly related to their bottom line if they can get motivated and inspired to do so and believe it's good for the health of their population. The challenge in my mind, it seems to be for physicians, and I've been thinking about this, but I don't feel like I have a good answer, is climate change is not the most pressing issue this afternoon in clinic. Like, they're like, I get it, and maybe I'm seeing more cases of asthma, but at least it doesn't feel like, but I have 18 patients to get through this clinic, or I'm on the wards and I have 12 patients on my service. It's not clear how climate change and the linkage that, even if on the background we can say, well, there would have been 8 kids with asthma, not 12, if climate change wasn't happening, or tomorrow there will be 20 kids with asthma. I get all that, but I got to take care of the kids with asthma. Help connect the dots of how you get people whose job it is to take care of patients in front of them to own that more than they have so far. And I do, by the way, just generally agree, this is a huge opportunity, and I think we can do a lot more, but not until we overcome this barrier.
I think we should just ask Ari.
Actually, for everybody. Yeah, that's a good question for all three of you.
Okay, but Ari, you start because you kicked this off, this avalanche.
I created this problem. I own it. Okay, so a couple of things. So the first thing is physicians care about the patients in front of them. They also care about the ability to provide for those patients. So I think in part, the two questions I would say is, I would ask someone who says, why should I, as a clinician who's practicing in wherever, non-coastal and even coastal, why should I care? And the answer is, you want to have medicines in your clinic. You need to understand that when these extreme weather events hit the coast, it's going to dramatically, I mean, this is in the United States context. I mean, overseas it's even more direct. But and this is backed up by the National Health Service in Britain, did a risk assessment of climate change to the National Health Service. And the number one risk was supply chain disruption. They were anticipating huge disruptions in like things like IV fluids. Like, you're going to have a patient come to ER, and if we've had a storm of this strength, you can have a 50% chance of having adequate IV fluid supplies. The second, and this gets to the cost piece, which I think is critical because that's where the minds are, it astounds me the extent to which leaders of major healthcare institutions do not understand in this realm, and Massachusetts is a good example, in which everyone's talking about costs being an issue because we're moving to accountable care where essentially we're capitated. The built environment that we're building is not in the equation. So we're not thinking about, wow, we could actually contribute to better air quality in our communities, reduce greenhouse gas emissions, and decrease our energy costs. And it's just not there for the vast majority of healthcare operations because this is being recorded, so I'll probably be held accountable. But the truth is most of the people running these shows have no idea about any of these things. And I think that's fair to say. But I think you're absolutely right. I think that we need to do a much better job of figuring out how this message gets to their interests. And I think primarily when you hear about efforts to educate clinicians or nurses, it's the public health messaging. It's climate change is going to cause mass disaster. And physicians say, well, that's terrible. And they're going to come to my ER, but I can't, that's not my job. So I totally agree on that point.
I think it's actually you're getting to two very fundamental things. I think one is an awareness that this is actually going on. So I actually think clinicians may be seeing more asthma in their clinic. They may not actually be making the leap and linkage to what is causing that. They just, because it could be any number of things. So part of it is actually creating the continuing medical education, sort of the opportunities for educating these physicians. Because when physicians do see sort of things sort of happening at an epidemic level, which I think is where we're starting to hit that tipping point, they do start to act actually in more. So I mean, I think that one, it's actually a barrier between making that connection. I think the second thing is that when you look at what's happening in medicine in this country, period, the assault on the profession as a whole is pretty profound. And the debate we are having about how to survive as providing health to a population is pretty profound. So to throw environment into that is sort of one other thing amid what is our payment structure, which we do sort of care about because, I mean, I'm sorry, when I'm away from my family at 2 in the morning in an ICU, like, you got to know that you're going to at least get something, it's going to at least put bread on the table. I mean, so that is part of the debate that we just have to acknowledge and be okay with to some degree. But so when you're putting it in that spectrum, I think then it becomes a question of what are the priorities for physicians and clinicians and where does this fall? And so we have to help that bump up. And I think it goes to the argument. and making the leadership of these institutions understand that, because I can guarantee you they don't. And I know this is recorded, and you can hold me accountable on that statement. The third thing that I would just add as well is that physicians and clinicians are terrible advocates for the profession. It is why we are in some of the situations we're in, because we are not trained to think this way. We're not trained to be advocates. We are not trained. We're trained to take care of people. And that's what we're really good at. And guess what? That's what our skill set is. That's why we went through medical school and did all that crazy path to be where we are, because that's inherently who we are. And I think that the advocacy piece is much more foreign and difficult, and therefore to coalesce around this is a very, there needs to be tools, and there's going to need to be strategic partnerships in order for that to happen, and hopefully it will. But I think those are just sort of the things that I would add.
I'll just make a brief comment, and that is that this particular case that you're describing reminds me of the fact that we don't really connect the dots. So there we are treating a whole bunch of cases of asthma, and the idea that we respond to the illness rather than prevention, of course, which is what you alluded to before, is the key. And to connect the dots for an educated citizenry, of which doctors are among those, would require that we would understand, of course, that it's the particulate matter, and then you'd look around the hospital and think, damn it, it's too cold in here. What's the air conditioning at? Why are we've got space heaters in the summertime, which is what we have in Washington all the time. People having to dress like it's the winter in the summer because we're burning so much. So there are so many ways in which we're not connecting the dots that have a long cascading impact on what kinds of things emerge as our health issues to address ourselves.
Can I just make one quick add-on to this? It seems to me that there are plenty of models for this in terms of, we've seen this with violence in the emergency department where the surgeons finally, the trauma surgeons are like, I'm sick of just constantly patching up people, what's going on in the streets, and have gotten engaged and have connected the dots, or somebody's helped them connect the dots. And so there are lots of models, not the first time we're encountering it, but I started off a little skeptical in the way I asked the question, but I think all three of you certainly gave me a lot more hope.
Well, let me just add, that's the role of emotion, where you think, what's going on here?
Yeah.
And that's why I say it's so important to have this, not some kind of a cerebral analytic premise, but where you're feeling something, because that's what drives people to take action.
Thank you. More questions? Jack.
Jack Spengler. Just on that last point,
Oh, it's Jack.
Lise. You know, talk about emotional connection. So when I ask my students, even my kids, you know, who are adults now raising their own families, about how they worry and think about climate change, it is, they don't connect emotionally to it. They think technology. Oh, they have such faith in our ability to invent our way out of this that technology will take care of it, someone else's problem. So how do you address this disconnect with the emotional connection to the crisis that I share with you we face?
Okay, well, yeah, well, we all have these dependency issues. We saw back in November that we were pretty convinced that the political system was going to take care of us one way or another, and when we got it exploded in our face, and I don't care this is recorded either, that we all had it. We all.
Nobody cares.
Wait,
That's
right.
good.
Well, we'll go down together. We headed for the streets because we realized there is no magic parent here, or at least we have at the moment. But so that issue of a dependency, oh, someone else will take care of it. And, you know, that's a temperament issue. That's an experience issue. People are different. The children whom I have been talking to, 115, 170, just this week, were telling me that these were the worries that I referred to here. And as a matter of fact, they wondered, they were sorry to say, but that morbidly, they admitted, that maybe a pandemic would be the only way that the world could be saved, because we would wipe out the species that is causing so much harm. So there's a big range of how people connect emotionally. And again, it can be the temperament of the child, the experience, the faith in parents, any other number of things. But how to get those people to feel something who haven't before, the usual way is to bring them to a place where they can see social injustice. And they see it over and over again. It's a repeated emotional experience, and they see real suffering sometimes for the first time. A lot of people we live in a bubble. We've never had to see some of the ways that people suffer. And that is the most, I think, effective way to awaken people to what's really happening.
May I come on this, weigh in on this? I think from what I hear from you and some of the people in the audience, there's a lot of trust in doctors. I mean, yes, they do also, they look at the bottom line, but they are basically caring also in the emotional sense with patients. So if the doctors could be convinced to be also advocates and messengers of this, that would be a wonderful impact. As pediatricians, we care for the next generation. The next generation will suffer much more than we do. So we have a problem that to convince the medical profession of their potential to be advocates of this problem of climate change and the health impacts and how to solve them in a positive, emotional, but positive way, I think. And many people said today the health crowd is behind the curve. Yeah. In their knowledge, in their interest, in their commitment. I mean, we are an awkward bunch here, not representative. So we need to address them. I don't know how, through medical associations, we have to think this through. Through teaching the new generation, but the existing doctors who are beyond their usual teaching phase, we need to reach them with continuous education. We have talked about MOOCs. We have to come up with ideas that reach these perfect multipliers, if I may say so, because they join authority and they are not known as necessarily activists or in one party called, but they are concerned with your health as a patient. And if you have a message bundled in your personal consultation or outside your office. Maybe you want to...
Well, I think the thing that I want to add is that, you know, when we talk about climate and health and this communication, how does it matter in the emotional? It's really interesting to, raise this issue of emotional, because when it gets personal, that is what motivates people to actually do something. Right. And so, but, you know, it's funny too, because when you just look at health in general and our whole discussions about how much are we going to pay for health as either an individual or society, you look at like the ACA and some people are opting to get taxed, right? Rather than buying health insurance because they sort of don't value their personal health or it's not real for them in a way that they don't think it's worth the money, right? So that gets down to this just very fundamental question of how do we value health in general and our own vulnerability to it? Because for this to actually happen, it's got to get personal for people. Like really profoundly personal in a way. And that's the challenge I think that we all face, is to not have this be in the abstract and have it be scientists and doctors, because it is the want. That is such a great example. Like often when doctors, there's so many times I've talked to patients about their prevention and their health and I can just see their eyes glaze over and they're not listening, right? I'm guilty of that too. And so I think that how do we, without fear, but really, you know, because I don't want to go the fear road either. We're living that way too real right now. But it does have to become really personal, I think, for people to make that connection and for this to really become something tangible that folks understand. And so, but we're also up against a bit of an uphill battle because I think we're doing that just on people valuing their own health in general. So it's a double whammy, if you will, that we're trying to surmount to some degrees.
More questions? Yes, please. Just a second.
I'm Sharon Byron. I come to this from
the mic arrives.
I come to this table with a systems background, so I look at healthcare systems from end to end. And the new healthcare system business model now has the doctor saying hello to the patient, the physician's assistant doing the work, or any number. And at my age, I've gone through my recent medical set of events, and I always have to ask the person, who are you? What hat are you wearing today? Because I can't always tell from the uniforms. And I find it very costly because no longer, my PCP is my general manager of my accounts, and when I go to, then I have to go to each doctor and do these copays. And that's where it's getting really crazy. So I'm really hoping that if we can just get that mantra out of the clean air, clean water, and start acting on it, and make people understand that they can feel better, if they exercise, if they eat right, and if they do these things, then they don't have to pay all these co-pays. So that's sort of my, that's my philosophy right now, and I happen to be doing very well, having had very sick parents. But I've also been through working with some difficult 93-year-olds who are very healthy, but we got to put them into these healthcare models because their kids are too busy to take care of them, so they have to be in assisted living, and then that's very costly. So I don't know how we're going to get the costs down unless we start really focusing on the environment and getting it clear, because then we all win. So I really want to thank, everyone has been very, very enriching today, and I really commend all these panels and the whole team that's been brought together today, because this has been great for me. So thank you very much.
Thank you, but we need to answer the issue of costs down. There was a question in your...
Well, to keep the costs down, right.
As a motive, or how would you link this? I'm not clear what the message was.
When I tried to put together...
Sorry.
When I put together a healthcare system, what it really meant that if we had good electronic record keeping, we would be able to cut the cost down, because then my medical records would be in front of my doctor when I'm seeing my doctor. Because when you have missed medical records, you have a problem. But what has happened is they miss the message, and instead, for every doctor I go to see, they want new information for their new medical system.
Okay.
So nothing is integrated. And that part is what's really hard in the present medical system. And I represent the baby boomer group, so we're that big bubble.
It's a statement of a problem of the current healthcare system. Okay, thank you. Anybody else? Anybody from the younger generation? You have been very quiet today. No? Yes, there we go.
I was going to say, Jack already spoke.
Hi, I'm actually not from the medical or the scientific, or I just care about the environment, and I'm an artist. And today's just been mind-blowing hearing all this stuff, and wonderful. Thank you. But I guess my question is, what do we leave with? What would each of you like us to leave with? Being positive and ready for action. I guess that's my question.
It's very good. Does this lead to your closing remarks, Ashish?
I'm happy to give my closing. I don't have much.
Maybe everybody here can give a message, and then Ashish, you give your...
Do you want to say something?
Yeah, well, we go...
All right, I'll weigh in. First of all, I think that we're always most effective at what we feel most passionately about. So, and it's also well known that in any discussion with groups, if we're a member of the tribe already, that we're already accepted, as others have said. We use the same language, they trust us, etc. And speaking about common values, of course, is always important. So in any way that we can reach to people whom we believe are already going to listen to us, that's an important thing, and that is going to be determined by who we are individually. Many messages, many messengers, many places. There isn't just one way. So there's that. But then there is something that I do feel fundamentally, and I hadn't thought about it in a long, in many of the years that I've been doing this, it has just now begun to occur to me that it really is something fundamental to understand as we seek to create social norms and to speak honestly and transparently and humbly, that we look at our own personal carbon emissions. What are we doing? How much are they? Where can we make those cuts? We can see how hard it is or how easy it is. We can see what kinds of things are healthy for us. And we can also see the ways that we can now speak to the people around us, because it's not going to be coming from the federal government for a while. It is going to be coming from bottom up. And what we do influences the people around us, creating the social norms, and those social norms drive markets. So I really do think it's critical you manage what you can measure your carbon footprint, see what you can do, and take it to the road.
Ari? Yeah,
So,
just go on.
Thank you for that question. I am the descendant of many artists, And they would be very, I think, proud of me at this moment in time to say that art is powerful, and that I would completely agree with Lisa in that our passions are, I mean, first and foremost, starting in the room, what you leave with is whatever you're doing, what you're passionate about is the mechanism through which to take action on this issue, and that takes a million forms. But I'm reminded of the Works Progress Administration in this country, in which artists were salaried by the federal government to essentially make propaganda. That propaganda remains, unless it's been removed from certain state houses, in government buildings in various places around the country, but it persists. Did anyone notice Thomas Hart Benton in Obama's campaign logos? It's there. Benton was one of the creators of the image of rolling hills of grain in the United States. And if you remember Obama's slogan, one of them had those parallel lines. Well, that was a reference to Thomas Hart Benton. And if people were more savvy in art history, they might have started saying socialist, curse, you know, whatever. But it's impregnated into the American mentality that we're a country of beautiful rows of grain. So in your role as an artist, I think the key issue is actually analogous to what we talked about earlier, which is how can you use your talents to communicate to the people who aren't connecting the dots, or who have what I would argue, the wrong-headed tribal affiliation, which is climate change is about giving over sovereignty and whatever you've heard today. And the challenge, of course, is that I'm presuming you live on the East Coast. We need to communicate to the people who are not on the East Coast, frankly. So artists are also wonderful at collaboration. They're wonderful at community formation. And you can imagine that in the right place and time, having art that reflected something about America that was either at risk or that could benefit related to this change in climate in the right way from the right person could be immensely powerful. I mean, think about what Annalise showed about the French campaign. Liberty leading the people. I mean that was pretty blunt, but that is powerful. I also have to mention that if you don't know, the state of Massachusetts right now is considering a carbon fee and dividend program, which is to say that the state would assess a fee on carbon applied to all non-electricity uses, which is mostly fuels, so gas, jet fuel, whatever, and all of the revenue generated would be distributed back to taxpayers, so it's revenue neutral. This is based upon a very successful program in British Columbia. And as far as making progress in the absence of federal leadership, there are endless numbers of ways, of which you heard about from Gene McCarthy, but if you know the history of the Clean Air Act, you'll know that that was not a federal mandate. That was not people in Washington saying, we've got to do this. It was businesses who are having to comply with different air quality standards in California and Pennsylvania and Ohio and Michigan, begging the federal government to give them a level playing field. So we have California, which, as you heard, is the 5th biggest economy. We already have RGGI. Massachusetts doing this and showing that the state's economy will do well, which it probably will, could be immensely powerful to convincing other states that are on the fence. And I'm thinking New York would be a good one. I have relatives in Florida, and I just, for the life of me, you would think if any state could get its its sensibilities together. But if 2 or 3 more big states economically did this, it would be huge. We in Massachusetts, although I would argue we're generally powerless in this national conversation because we're small and we're leftists, whatever, but if we do this and can demonstrate that it's good for our economy, it will be potentially immensely powerful to other states to take action. So both very hopefully personal one, but also don't underestimate the power of Massachusetts to set an example here that could be highly influential in national discourse.
I had just 2 quick points. I think we need to change how we view this, and that speaks to it a little bit. If you start to demonstrate that we can make investments that pay off economically, again, for whatever reason, that does resonate with the human being and the individual in an understandable way. But we need to change our arguments, right? So it's not what does it cost to do something, it's what does it cost if we don't make these interventions. And to start to frame that, I think it will motivate people differently. And the second thing is, it is every single person in this room's responsibility. Mm-hmm. It's mine. It is yours, whether you're an artist, whether you are a taxi driver, no matter what you do or who you are, you can play a role in fundamentally shifting how we talk about things and demanding a shift in conversation. And we are in the East Coast, and that is the challenge, but you have a cousin in Kansas. Call them, genuinely. I mean, we have to be engaged, and I think that We have to stop thinking somebody else is going to fix it for us. It's all of our responsibility.
It's just what I wanted to say. I want to expand on this. Don't think that health and climate change is the task of physicians only. We have a special role here, but it's very important that many non-physician, non-health people absorb these arguments because they are so powerful in communicating with policymakers and with your mayors and so forth. So this is not a specialist sort of esoteric knowledge that we have. We should share it, and you should use it. This said, physicians have a special role because they see patients, they have a certain authority. So we need to work in our profession, which is unfortunately very much behind in terms of ownership of this issue, to tell them and to reach out to leadership of hospitals, to reach out to colleagues, so that this profession can be a special role. But we are not the specialists of health in general. We may be good at healthcare provision, but health is everybody's issue. So is climate change. Thank you very much. I think with this, we want to thank the panel. And I hand over to Ashish.
Thank you, Rainer, for moderating that, and thank you, Ari, Vanessa, and Lisa for a terrific panel. All right, so for those of you who are the brave, the proud, who've stuck through to the end of the day, one of the very few things that I believe very, very, very strongly is you should always try to finish on time and maybe a couple minutes early if you can. And it's 2:24, and we're going to finish in 2 minutes. So I do want to take 2 minutes to thank all of you for staying with us throughout the day. It was quite an amazing day. If you think back to where we were, for those of you who were here at 9 o'clock sharp when we began, with Drew, with Michelle, with Gina, and leading into the panels, I want to come out and kind of just highlight a few things. I want to start off with a quote that Michelle Williams, the dean of the Chance School, that she's used before, which I think is really powerful, which is, she says, health is the human face of climate change. And it is both visually a very powerful image. It is also a very clear way of describing something that I think we have done an inadequate job of, which is explaining why climate change matters to all of us and humanizing it. And I think the public health community, the medical community has been late to the game. But I like to say, better late than never, and we are here. And I think it is our job to get moving. There's so much amazing stuff from Gina's conversation and things that I am not going to make any effort to summarize it. One of the key things I walked out of was she basically said, and it's interesting because she went back and forth between really being optimistic and then having moments of, I can't believe what's happening in Washington. But what I fundamentally got out of it was, don't over sweat the federal stuff. That, in fact, there is a ton of progress that happens at the local and state level. And in fact, most of the progress always happens at the local and state level. And if you get 5 states doing something here and 3 states doing something there, it actually creates pressure on the federal government through all the mechanisms that we know influence federal government, like corporations, like other interest groups, to do something at the federal level. And so our job is to act at the state level, to act at the local level, to create the pressure that ultimately will lead to federal action. But that's the last step. It's not the first step. And I think in some ways we've gotten lazy over the last 8 years because we've had a guy in the White House who's pretty committed to these issues. And so we said, we don't have to do that much at the local level because we've got this guy. Well, that guy isn't the president anymore. And so we have a very different set of challenges. But we have to go back to where most of the progress has actually always happened, which has been at the local and state level. Couple of other points, and then I'll finish up. I think one of the things I took out of today was the issue around connecting the dots, right? It's really hard with climate, because we think of like the weather outside, it's sunny, but climate is something clearly much bigger and more complicated than that. And so when we look at things like Syria, think of it as a conflict, you kind of tie it to the Arab Spring, and we do not, we don't connect the dots to all of the other stuff that's been happening. And I think that first panel was really powerful, whether it was talking about Darfur, whether it was talking about Syria with the stuff that Jennifer presented, showing the connection between broader changes in climate and what actually happens on the ground in terms of the manifestation. That much of that was a national security conversation, but the health effects are very substantial in there. And I want to just say that in the last panel, we essentially did the same thing. And I asked the panel to kind of help us connect the dots, and I think they did it quite brilliantly. How do you get doctors and nurses and other clinicians engaged on this topic by connecting the dots between what they do on a day-to-day basis and climate change? Last couple of things. The panel that I got to moderate I thought was super fun because both of the speakers brought very different perspectives, but really important ones. And what I got from Annalise was the idea of the public. So a couple of things. I mean, one is, we finally have been talking much more about climate change over the last 10 years. You see it in the press. You see it in Le Monde. You probably see it in the New York Times. But the blue bar underneath it that was about climate and health hasn't really had the uptick. And that's our task. Because, as she said, that begins to close the gap, the distance that people feel from this issue. And that's really powerful. And I thought Jerry was, a little different, brilliant, really insightful, and a set of voices and a set of perspectives we get too little of in places like Cambridge. And he took a lot of assumptions I had about how do you move the political debate and basically said I was wrong. And that you have to do it in a very different way. And I actually think, I'm pretty sure he's actually right about this stuff. And so we have to think differently and act differently and engage very differently if we're going to get the center right to care more and engage more on this topic. And he's absolutely right. Without that, we can convince ourselves and have great symposia and great conferences and walk out feeling passionate, and that's great. But eventually, if we want to move the national conversation, we're going to need them on board, right? And Jerry, I think, provided some very helpful tools. So I'm going to finish up by just where I started, which is I said it's time for action, right? It's time for us to act. Today was meant for all of us to learn. I feel like I've learned a bunch of stuff. I hope you guys have all learned a bunch of stuff. And I think each of us has to figure out how we act. For me, on a personal level, I think the idea of a personal carbon footprint is a really interesting idea. I have not thought about trying to calculate. The levers I have as a physician, as somebody who engages in the medical community, one of the things that we have done at the Global Health Institute is said this is one of the most pressing issues facing global health over the next 10, 20, 30 years today, and have made this a major priority. I think all of us have to sort of think about where are our own levers, where can we engage, where can we have effects. And then if each of us, even everybody who made it to the end of the day, if each of us commits to doing just a little bit more on this, we can move Massachusetts. If we move Massachusetts, we can move New England. And if we move New England, you start creating real national pressure for action and international pressure for action. So I walk out incredibly optimistic about where all of this is going. Thank you all for joining us, and stay engaged.